This is always, I love these, this portion of the moment, because we like to take a breather and say, what sticks out? You've had a night's sleep from yesterday, our first day at Transform. What speaks to you here this morning?
Well, there were three things that were on my mind yesterday after listening to the presenters, as well as some other structural elements. But we heard about connections, connecting databases, connecting machines, technologies, connecting people across distances. We heard about relationships, and we heard about behaviors. And at the end of the day, there was a discussion about how can we take all of the big emphasis on big data, use that to help make people, individuals, make decisions, learn from that and turn it back into data that we can use to get better. So quite a spectrum going through that. And truly, if we think about health and healthcare, health remains fundamentally a deeply human experience. The opportunity of technology allows us to make the outcome of health better, and probably the process of healthcare as well, but has some inherent challenges and risks. And so I think the great opportunity for us is how we can manage that for the benefit of everyone, especially the people who depend on healthcare providers for their interventions, as well as the people who are providing healthcare in their actual day-to-day work.
You know, there's this, until you know better or until you know otherwise, the concept of transform and the work you do seems contradictory, because the word says transform, which in my brain says new. What's new? What are the things we can do tomorrow? What is the next 10 years in medicine? And your whole point, the flag you've planted, really talks about getting to essentials. It's not necessarily getting back to essentials, in so much as maybe we have never found the essentials of that human connection, of how we are a doctor and we are a patient, and how that interaction works, and where health happens at its best, and therefore healthcare happens at its best, is in the simple stuff that we're still working on.
Well, it is. I was thinking about that in the context of a couple of things that started, again, early and late. And so in the early session, we had the expression of how in the U.S. we're trying to solve problems of rural healthcare in southwest Kansas. Again, thinking about relationships. So Ben used a couple of those to illustrate his presentation. And then later, juxtaposed against that, is this remarkable application of technology, simple to use, in Brazil, in facilities that would be entirely different than what you would expect to see in the US. And so it makes you think immediately, what is it about US healthcare that requires palaces of healthcare when we're missing the connections to people where they are? And so thinking about today, the rest of the discussion today is to turn that around and say, then, how do we change what we're thinking about, or what we've been thinking about, to what we would do for the future, and actually connect to people where they are, and use technologies to provide health and health care in a different way?
That gets down to the concept. I mean, what you imply there is that Brazil, for example, has graduated, or maybe never even had in its brain, the concept that healthcare needs to have hospitals.
Which is a great observation. And if you look at underdeveloped countries, they often make that leap past what we would have thought of as a natural progression of technology. And so I see that in the example that Raphael brought. And honestly, if you can do that in Brazil, you can do that in northern Minnesota, where we're running into difficulties of having access to delivery services, for example, or anywhere else in the US or the globe for that matter.
But then you get to the public. Like, you could strong arm your side of the equation into rethinking that.
Sure.
But I, as the patient, might expect it, right? My gestalt is, well, I have to go to a place that's a hospital if I'm going to get that care.
Well, the behaviors are also interesting, and that also came up from my perspective in listening first to Heidi, and then later to Dan Ariely, and then even later to Darshak. So Heidi was pointing out the opportunity to have access to physical therapy, and she did highlight that for certain conditions, some simple things are actually preferable to high-tech or surgical solutions or pharmacologic solutions, drugs, pills. And I was reflecting on that and thinking, as a physician, I mean, even as a cardiologist, we have good science, randomized trial data, supposed to be the best evidence you can get that says, you know, for chronic back pain, chronic knee pain, surgery is no better than simple things to start with. And even for things like coronary artery disease that I deal with, we have good science that says it doesn't matter whether you start with simple medications to treat somebody who's having chest pain or angina, or whether you start with an angioplasty, a stent, or whether you start with a bypass operation. At 10 years, the outcome is the same. So start simple and then go through the progressions you need to. But there's something about the human condition, both for patients and for physicians, that drives us to go to that technologic, that surgical, that pharmacologic, that more expensive solution. I have to confess I was a little bit disappointed when I listened to Dan. Maybe I knew it before, but when he explained that humans are hardwired not to think of the long term, and I thought to myself, I should have known that. Maybe I knew that. I've forgotten that, but it changes really how I think about how I'm going to try to engage people in conversations about what they should do for their health.
But again, if I had chest pains this afternoon and then, you know, left Transform and came over to you, and we did all the tests, and you said, I'm going to give you medicine versus a stent, I see a little bit of something in there. There's a little blockage or something in there, but I'm not going to do anything invasive. I think I would feel cheated. I think I would wonder whether that was the best care.
Well, I think that's really the challenge for us, is to come back to realizing that health care is still truly a relationship, and it's built on trust. So I have to be able to listen carefully to what is affecting you, come to a conclusion about what we should do, and to be able to impart to you the information you need to make a good decision, and one that will give you a strong sense of confidence and trust that together we're making the right decision.
But legally, don't I have leverage in whether
I can do whatever
I want, right?
You
right?
can.
So if I sit here and demand the stent, at some point you're going to have to give it to me, right?
Well, that's always the sort of the tenor of those discussions. And I would have to say that it is often a circumstance where people might be surprised in the beginning, but when they consider the options, they will generally come to the correct conclusion. More often than not, what I encounter is somebody coming in saying, I want a stent because that's what my neighbor said I should have. But when you explain, or when I explain to them that a stent is great if you're having a heart attack, but it really doesn't do a lot if you're not having a heart attack, and oh, by the way, I could give you a heart attack by doing the stent, then it usually changes the perspective.
Who do you think needs to move more? The other thing you cited with me is studies that show that for some of these pain situations, you know, where opioids have been prescribed, that Tylenol really would have been just as effective in so many cases. Who needs to move more in this area? The providers, the doctors, or the patients in what they think?
I suspect here is probably more the providers, and the providers need to be able to understand what the concerns are of patients and then address those. So there are lots of ways that you can manage pain that don't require an opiate, including some now simple things like lidocaine patches that you can put on your skin. But again, Heidi showed very, very convincingly that simple physical therapy can work very well. And what we don't tend to have the chance to do in a conversation about, say, chronic back or knee pain is, well, if you do a surgical intervention, there's a fairly prolonged period of recovery. It's not that you're going to be better the day after tomorrow or the week after next. And there will still be potential for difficulty later on. So start by reframing what you think of as this condition being.
The crux of where, you think back to when you went to medical school 10 years ago, and or to even how medical school is now, you're learning the nuts and bolts. You're learning about angioplasty. You're learning about this, and this, and this. And then at some point, I presume there are a roster of classes in medical schools that teach you about human behavior and how to actually interact with people.
There really are not. I hate to disappoint you. We're recognizing that we need to do more of that, but at the same time, there's just so much more medical knowledge that has developed that the curriculum has not lengthened. It's still a 4-year curriculum. Mm-hmm. And so it's a matter of making some trade-offs about what becomes more important.
I mean, it's the Patch Adams, right? It's the Patch Adams example, which, it's a fine movie, but then it gets ingrained in our head that if you're not at that one extreme of, putting on the rubber nose, then you're a failure completely as a doctor. And we don't need everybody to be Patch Adams in that regard. I mean, I think a lot of people as patients would have examples of,
sure,
I could use just a little more human connection
yes.
here.
Well, and in fact, that's a concern in terms of modern technologies, using electronic health records that require me as a physician to sit at a keyboard and do a lot of manual entry, immediately create a barrier to communication or a barrier to developing a relationship with the person I'm sitting with, trying to help understand their particular health problems. So technologies have the possibility of liberating us, but they have the possibility also of confining us. And so our great challenge is how do we actually use technology to make our work better and make the experience of people better. Now, Raphael's technology, mm-hmm. I mean, compared to what I do every day in front of an electronic health record, his little touch screen, give it to me now. Because that makes it possible for me to have the interaction with the person I'm in the room with without having to take my time to interact with the device.
What do you think is keeping you from getting that installed today?
It's kind of interesting. At the Center for Innovation, we did a project 3.5 years ago that we called Project Mars that was based on using iPads and touch, simple touch. And physicians who used that with patients found it very easy to just do their work, but patients really liked it because the physicians were not engaged with the computer in front of them. Mm-hmm. They would listen to people, and then you would also hear the physician essentially repeat what had been said as the patient had explained their story.
Because that's dictation into the
Exactly,
iPad.
It was dictation, and that gave the patients confidence that they had been heard, that we'd listened to them and understood them.
So what's keeping you from having that installed today?
More than anything else, I would say it's an institutional commitment to hardware and workflows that are imposed by an electronic record.
What's the 5-year plan for addressing what you think should be addressed on?
As we've encountered some of those difficulties and we've gotten the electronic record implemented, it now gives us the time to go back and think about how we can change that for the future. So we're pulling those things back off the shelf, thinking about how we can change those.
There is the theme we're honing in on for this conference is decisive moments.
Yes.
And you could argue that as Mayo, this storied history, 100 years-ish, this is a decisive moment if we're to think of the next 100 years of Mayo.
You could. It was a little more than 100 years ago that the modern Mayo Clinic, in essence, was founded when the Mayo brothers donated their entire net worth to the Mayo Foundation. And the earliest innovation for the Mayo Clinic was the integrated group practice of medicine, to bring somebody in, listen, apply all the specialties that we could, again, in a coordinated and connected fashion. So here we are 100 years later, and thinking about, in essence, doing something even that the Mayo brothers did back then. And they would often, even though people would come to their offices, they would often go to people at home. And especially in their younger years when they were working with their father, it was home. Now, when we think about what we might be able to do with technology, I mean, Raphael's example was a good one. We have the capacity now to project our knowledge to people where they are. And it is going to be increasingly possible that we can take things that we would do now, even in hospitals, and move it to where people are at home. So this century, so almost 100 years later after the Mayo Foundation was started and after the clinic was developed on this concept of an integrated group practice, if we think about what we heard yesterday, the connections that technologies offer give us the chance to create a stronger relationship and a curing relationship with people. And so as I think about that and what Mayo has announced in terms of its new vision for 2030, including the relationship with Google that we're going to hear more about today, and the concept of a platform that we'll also hear more about later this afternoon, I hope as a clinician at Mayo Clinic that this will be the beginning of a new century of innovation in how we actually deliver health care to people and improve health. And if we don't do that, then my personal assessment is that the Mayo approach or the Mayo-Google relationship or whatever relationship that we have will have not lived up to its potential.
Do you lie awake at night thinking about what will all look like in 20 years?
No, because I don't know what it will look like in 20 years.
I mean, there's a lot of construction going on right now in Rochester.
There is.
To build up Mayo specifically. Will this, whatever's being built, be necessary in 100 years?
There will always be a need to have locations like this where you can do the advanced work, including the discovery, where you can move discoveries from the laboratory into patient care. But I think we know now that it is possible to deliver health and healthcare in ways that don't require big buildings. And really, the investments that Mayo Clinic will make over the next several years may not be as much in buildings as they have been in the past. That digital infrastructure will require a commitment of resources. And so that's one of the reasons that Mayo has announced its new strategic plan, including partnering with others who are interested in that direction.
When you think about, and we're going to have this conversation with Google as well, but we talked a lot earlier in this conference about the privacy issues and what's coming in that regard, and that how do doctors interact just with our data, not just even in the personal, whether it's an iPad or a computer keyboard.
So we'll hear a little bit about that this morning too from Jim Hunter, but we heard some of it yesterday. Chris Ross and Ben Fry in particular emphasized the importance of data, and that you have to think of the data and make sure that you respect the integrity of the data, as well as respect the privacy of the people. So we must keep that in mind. A future healing relationship will not succeed unless we can secure that trust, that privacy is going to be protected where it's necessary, but we can find a way to use all of that data to help us as physicians make better individual decisions for people, that N of one, and then bring that back to a larger data set to learn from.
There was a really interesting presentation yesterday from an executive at a healthcare or a health insurance company. And he was showing us some amazing statistics about how you can reduce this or lower that or increase this. And we were chatting a little beforehand, but it would be amazing to put some of those slides, like around opioid health or teen pregnancy, or even just the cost of stuff from the insurer's perspective into the clinic. Because when I ask my doctor, I don't ask my doctor how much that's going to cost, because he's not going to tell me anything because he doesn't know. But it's interesting to think of the future of care, that decisive moment, as actually saying, well, actually, let's talk about your options, whether you get the stent or whether you get medicine, not only from the perspective of your health outcomes, but how much you have to pay.
Absolutely. And so connection of databases and connection of resources, non-clinical resources, could help us immensely in that conversation. So we had an idea a few years ago in the Center for Innovation that we would create a capacity to advise people, first based on the medical knowledge, and then next based on what we know about their insurance coverage and their finances, and then give them additional information about, okay, well, you know, this is what you might need, and here are the places you can go get it. And it might not be that Mayo Clinic is on top of the list. We didn't have a way to scale that because we weren't able to connect the databases. But going forward with machine-based learning and advances in computing, that may be in fact entirely possible.
So I come in to the clinic to see you.
Yes.
I have chest pains. You are able to do the EK, you're able to do whatever you have to do to figure out what's the problem. So you can tell me what the problem is, and then you can say, here's a slide that shows research that suggests actually we should do medicine instead of a stent right now. And here's another slide from a health insurance company that it may not be specific to your plan, but in general, here are the ways the costs would happen. What's keeping you from doing this kind of presentation today? You can't do what I just laid out today.
I can do the first part.
You can do the first part. You can tell me what's wrong.
But I can't do the second because I don't have access to the information from a company like United or from Blue Cross. Or even if you thought about a larger collection of data. So what if I took all of the insurers in the state of Minnesota and I could say it doesn't make any difference, you know, what insurer you have, the trend is the same. So here is why it's more important to think about an approach like this. So that being able to get that cost into terms that people understand is going to be critical. It's what is your copay? How long are you going to be off work? What's the recovery period going to be? Those have real financial impact for people too. For some people, no income means difficult time.
Is that what you'd like to get to, what I just described?
Yes. It would be fabulous if we could get to a point where we could have a very deep understanding of people, their desires, the factors that are important to them in decision making. Our research and innovation for years has told us that the single greatest fear that people have is that of affordability and cost. And the second is that the system is way too complicated for them. So we have to find ways that we can make the entire system more affordable, but also simpler and easier to use.
Is there, I'm always looking for the one thing that'll break the dam. Do you think there's one thing that breaks the dam on that?
You know, it might be this conversation that Mayo is trying to initiate of using a platform approach to medicine. Medicine for so long has been so insular that it has been difficult to crack that. And it may be that the partnerships that we develop with others will finally open that and make it more responsive to people's needs.
In the time you've been working on this side of the innovation side, so you're a cardiologist, but then you're also part of this innovation work through Mayo, through what's now the Kern Center. Has your practice day to day with patients changed dramatically based on what you've learned on the other side of the building?
It has changed immensely. Before I became involved, I would tend to approach things in more of an authoritative way, disease-driven way. I make the diagnosis, I say, this is the problem, here's what you should do. Now I tend to start from, tell me more about you. And as we get to the diagnosis, I explain to people that there are going to be different ways to do things, but tell me what is important to you and what some of your needs are, and then we will figure out what works the best.
Doug Wood, thank you so much for being here this morning.
Thank you, sir. Appreciate it.